Hello, everyone, and thank you for joining us today. My name is AYLA Ellison, and I'm the managing editor of Becker's Hospital Review. I'm pleased to be your moderator for today's session. As hospitals and health systems across the country continue the pursuit toward the quadruple aim, the shift from open surgery to more minimally invasive surgery is a hot topic, but the how is what is really important and what is talked about. This afternoon, we have a great group of panelists who have come together to share their experience in expanding access to minimally invasive surgery. So we're going to kick off today's discussion by having each of the panelists introduce themselves and tell us a little bit more about their programs. Dr. Battinelli, can we please begin with you today?
Sure. I'm David Battinelli. I'm the Chief Medical Officer and Senior Vice President of Northwell Health, also the Vice Dean at the Zucker School of Medicine, which is our joint school with Hofstra University. So our journey really began when the Chief Operating Officer teamed up with me to be the executive sponsor to oversee the development of the program. And our guiding principle was really, we wanted to do what was clinically the most appropriate thing to do, partner with our surgeons, and made really a deal with them that said, in exchange for outstanding quality and safety, and to partner with us to help demonstrate the proper metrics, we will continue to invest in this program. And it was really up to this committee to govern how fast we would move forward. And again, most important issue was really what was the quality, what were the safety, and what were the important metrics by which we could demonstrate the success of this program to justify for further investment and really pace it as we went forward.
Thank you so much, David. And Vicki, can you go ahead and introduce yourself and tell us a little bit about your program as well?
Yes, absolutely. Thank you. Vicki NEWMILLER. I'm the CEO at the Great Falls Clinic and Great Falls Clinic Hospital in Great Falls, Montana. And we have obviously a state that only has 1 million people in the entire state. And so we're in a community of about 60,000. Our service area is about 240,000. So we're a relatively small market. We're a small facility. We only have 19 inpatient beds, but we have a large competitor that's a not-for-profit facility. And we knew for us, as we were going to go forward with really trying to be competitive in our market, we knew that we had to do things probably a little differently and really try to set the stage so we could attract our patients and our surgeons to our facility. And so they would notice the difference when they walked into our organization. And we knew that the Da Vinci robotics program was essential to our success, whether it was recruiting physicians, whether it was actually recruiting patients that were actually willing to travel great distances in the state to get to the service line. So we felt it was essential, and the program has been very successful for us here in Montana.
Great. Thank you so much, Vicki. And Jackie, I'm going to turn the floor over to you now.
Great. My name is Dr. Jackie Martin. I'm the Vice President of Surgical Services at Barnes Jewish Hospital. I've been here for about 3 years. I was previously at Johns Hopkins for 31 years. So for us, when I arrived 3 years ago, we had a number of surgeons doing robotic cases, but we really did not have a robotic surgery program. So we weren't really leveraging the opportunity and the technology to benefit the institution. And what we did was, we talked about what we wanted. We identified the opportunity. We developed the interests. We defined clinical advocates along different service lines. And we partnered with those advocates to structure and organize our program so that we could get the most out of it, if you will. We developed a plan. We developed metrics. We developed even better risks. We've looked back and we've grown the program tremendously over the last 3.5 years, simply by organizing, by engaging, by building accountability, and making sure that we're better stewards of the institutional assets.
Thank you so much. And Jeff, I'll shift things over to you now.
Happy to do so. Thank you. So Jeff Burley, I'm with Banner Health. I've been with the organization 33 years. I'm currently the CFO at 3 rural hospitals in Arizona, all having robotic programs, which we'll touch on a little later. When I got involved with this program and with Intuitive, we purchased the first 5 original standard robots. And we realized at that time 5 hospitals were negotiating with Intuitive individually. And we really didn't have, like Jackie said, we didn't really have a program. We had individual robots at various hospitals. So I was asked as a rural or as a regional leader to be the liaison to Intuitive, to help Banner maximize and grow the program and help our facilities understand what they need from a robotic program and maximize, I think everyone's said that, maximize their robotic program. So I've been involved for 15 years, 13 years with Intuitive, and loved every minute of it, working with some really good people and helping develop our program.
Thank you so much, Jeff. And actually, when we jump in with questions here, I'm going to go ahead and start with you for this first one. So I'd love to hear from you. If you could tell us a little bit about what your initial goals were when you invested in robotics, and then tell us a little bit how that has changed over time as well.
Yeah, that's a really good question. I think initially, probably like everybody, we purchased a robot because we had competitors purchasing robots, and we had some surgeons coming out of residency that were asking for robotic or minimally invasive beyond traditional minimum invasive technology. So we stuck our toe in the water, so to speak, with the original 5 standard models. And then we continued to grow and realized that pretty much all surgeons coming out of residency, even 10 years ago, 5 to 10 years ago, they were trained in minimally invasive surgery, including robotic. And we changed from just offsetting to what competitors are doing. And we said that a robot is a minimum standard piece of equipment in each of our ORs. We're finally there for most of our larger facilities. We're not quite there for some of our real small facilities or critical access hospitals, but that's really what has changed or evolved over the last 12 to 15 years.
Thank you so much, Jeff. And Vicki, I'd love to hear from you on this question as well. If you could tell us a little bit about what your initial goals were with the investment and then how that's changed over time.
Yeah, absolutely. I think anytime you jump into a new service line, like Jeff mentioned, I mean, certainly for us, we knew that we wanted to be able to recruit physicians. We had several physicians that worked for us that were requiring this technology or asking for it. And then as well, we wanted to increase market share. We knew we were losing a fair amount of market share for people that really wanted the minimally invasive surgery. We didn't have the Intuitive or the robot yet at our facility. I think as it's evolved, though, we know now that data is our friend. And we know that as we're looking to really what is our future and what we can do to really make sure that we're cutting edge technology, but we're also making sure that we're using the tools to cut costs and to get the message out there to the other employers. So as we look at the outcomes and we know that our outcomes are good and we're using that data, now it's really trying to streamline it. We're making sure that we're using that data so we can compare the surgeons, so we can make sure that the surgeons are using the same dashboards and we can use the same metric, whether it's supply costs. And then as well, we're really trying to look at what we can do with that data to really make a difference, even to get it out there to the larger employers. So for instance, from our GYN perspective, for us, we know that it cuts costs in the hospital. We know the length of stay is lower. We know that the pain and the outcomes are better. But what we can also do is get out there into the community and tell the larger employers what we can do so they actually get the message out to their employees. And so, for instance, we have a group of GYN surgeons that are willing to actually reduce time away from work because they know that the outcomes are so much better with minimally invasive surgery. So for us, we know that we can help them reduce their overall healthcare costs, not just on the hospital side, but from the employee illness and those types of things. So we're trying to take the data with this program and really get it out to the community so they can see the difference of what we have at our facility.
Well, thank you so much, Vicki. I think that's very insightful into how the transitions happened over the years and then how you're using that data today. The next question is a little bit more about what's occurred over the last 20 years or so. So as all of you here today are experts in this, you've seen sort of the shift from surgeons using Da Vinci in certain procedures like urology and gynecology to now specialties such as general surgery, colorectal, thoracic, and many others are now on board utilizing robotics as well. So can you talk a little bit about what the financial misconceptions that you've proved inaccurate through building up your robotics program? And Dr. Martin, can we begin with you on this one?
Sure. I think, technology is always expensive. Surgeons always want the latest and greatest things. And for us as administrators and partners, it's trying to figure out where the real value is. And value isn't just the initial acquisition cost. And so many folks kind of looked at this as an expensive acquisition, and we're asking the question about where's the real value. When you're just starting out with a robotics program, if you're not looking at your data and analytics, it's hard to answer that question. And so again, having the data is going to help answer the question. And for us, then you begin to look at your KPIs, things like surgical site infections, length of stay, blood transfusions, all of the things that occur on the back end and that really bring value to the patient and value to the program. You can't simply look at your initial acquisition cost as the determining factor as to whether or not you should have robotics. And again, if you're going to be providing leading edge care in your area, you've got to have a complete service line of offerings, right? I mean, 40 years ago, everyone was doing open surgery. Then we evolved into laparoscopic surgery, and now we've taken it even further now into robotic surgery. And depending upon particular patients and their condition, the answer is going to be different on different days. But you've got to be able to offer the right approach to every particular patient, depending upon their clinical circumstances.
Thank you so much. I think that's such an important point, as far as looking past acquisition costs and sort of what's needed and what's sort of what your competitors are doing today as well. David, I'd love to hear from you on this question as well, just sort of the financial misconceptions that you've proved wrong as you've built up your program.
Yeah, I think that Jackie hit on probably the most important first one, which is everybody, understands that technology is going to be expensive, and then a lot of people will tell you, oh, you're going to save a lot of money on this, et cetera, et cetera. Certainly, that doesn't happen early on, but you have to put together a team that is going to be accountable for the metrics that will help drive your organization. And I think he hit the key ones. The one that I would add on that also is the amount of time in the OR and turnover of OR rooms, et cetera, which early on in this, there's no question that takes a little bit more time. What we found that through the development of a first assist nursing program, meaning nurses in the ORs licensed to be at the bedside, unlike technicians and others that could learn the technology, could improve our efficiency by over 30%. We actually have our own school of advanced nurse practitioners, PAs, et cetera. So it was really critical for us to have them partnered with each of the subspecialties, each of the surgeons who had their own idiosyncrasies, nuances, all that stuff that's important. But to the operators of the individual hospitals, turnover in OR time is a critical factor. So partnering with the nurses and developing this program was one of the most important things we did to satisfy that particular need. Others, as Vicki and Jackie had talked about, are clear, demonstrating that the quality and safety is what it is in the beginning, but just gets better and better and better, and clearly moves from discipline to discipline, procedure to procedure. As the surgeons have told us, there's no question that this removes a lot of the issues around dexterity. And in particular, for thoracic surgery, you are simply able to access areas that you just cannot access otherwise. So a lot of upside, but a lot of important work to be done at the same time.
And this is Dr. Martin again. I just want to pull on that thread about RNFAs. We have RNFAs in every one of our cases every day. And in addition to what was described, it also allows us to get our residents and fellows onto the second console and out away from the bedside so that they are actually learning, they're performing, they're actually doing more robotic surgery as opposed to, holding trocars and cameras and that sort of thing. So that's a key component to the successes that we've enjoyed.
Thank you so much, Dr. Martin. And Dr. Battinelli, I'm going to throw things back to you one more time here. I just wanted to hear a little bit more about, with more surgeons, and I know Dr. Martin actually touched on this earlier as well, but with more surgeons being trained robotically, how has that impacted access to Da Vinci systems?
Well, one of the most important things we did with our committee is make sure that the surgeons set up the proper mentoring, proctoring, and credentialing procedure for the surgeons. So our biggest concern was making sure that people had adequate training time and proficiency as they went on to, again, become more skilled as time went on. So we're a big place, as you know, 23 hospitals. We have over 20 robots. Everybody wants to use them. Fortunately, we don't want to be the police of that system, but our surgeons stepped up service line by service line and put together the proper programs. Now, one of the most important key things for us in terms of the program is because we have surgeons operating at multiple different hospitals. They'll have hospital A, who might only see a dozen procedures, but it turned out that person's doing 40, 50 at a different hospital. We aggregate all our data so that we can adequately credential and more importantly, privilege our surgeons for the particular procedures at the place. But be that as it may, we don't let just anybody come in and do whatever they want. This is really a very, very strict process. And when people know that you're strict, but that you're fair, they will adhere to it.
Absolutely. And Dr. Martin, anything to add on to that as well?
Yeah, what I would add is that as you grow and as we grow, for example, Banner has 23 hospitals, we have 15. We don't have robots at every center. We have certain centers of robotic excellence, and that's in our system, that's 6 hospitals. The other thing is, as you continue to grow your program, the most important thing is maintaining the safety and quality of the outcomes for clinicians and patients. And so growing the right way is very important, as was just described. And, we keep our eyes on the metrics. We measure everything. We look at the numbers of cases that clinicians are doing. There's a minimum number they need to do over prescribed time. If they don't meet that number, they've got to essentially be reproctored. So again, safety and quality is paramount.
Do you mind if I jump in here just briefly? Not really a physician, but I'll talk a little bit about what I've seen from just working with this program. What I've noticed when Banner started growing and we started having mixed technology, third and fourth generation technology, the SI and the XI, we were having some surgeons doing procedures really on an XI when it could have been done on an SI. So it was actually clogging up the XI for other procedures, more complex procedures from our general surgeons. So we actually went through a tiering process and said, these types of procedures can be done on either, but if the XI is taken from a more complex, that has priority, and we're going to move those procedures to the SI. We had a little discontent along the physicians initially, but once they understood what we were accomplishing and that they would get the XI time when they needed the complex case, then it settled down quite a bit. So I was just going to throw that in. As we grow, we're finding different things that happen along that growth spurt when you interject 2 different levels of technology.
No, thank you so much, Jeff. I appreciate your input there on talking about growth and sort of what your system is doing as well. I actually would love to stick with you for this next question that we have here, and it's about reinvestment. So when it came time to reinvest, could you tell us a little bit about what those strategies looked like, and then also just how you utilize the intuitive ecosystem to not only acquire the technology, but then to also maximize the investments that you've made?
Yeah, absolutely. Hopefully I don't get too long-winded. You can cut me off if I do. But the reinvestment was really a challenge. I heard earlier, I think Jackie, you mentioned that these are expensive pieces of equipment. The technology is expensive. Some doubt coming in right out of initially that where's the ROI coming from? But when we really studied, not so much how many procedures you're doing and how many are going to be done on the robot versus minimally invasive surgeries of other nature, and really look at conversions of open and really tackling that. Open conversions to robotic has amazing results. When you look at the data and dive into the data, you see a lower length of stay, you see less pain, patients going home on less opioids. With that shorter length of stay, you have that decreased cost. And in some cases, the robotic case is a little longer than open in some cases. But that's okay because of that length of stay reduction. We're using less medicines. The patients are up and walking much sooner and returning home and healing much faster, which gets them back to work quicker. And an organization like Banner that has about 10%, 15% of our organization that is the insurance side as well, we have to play both sides. We have to make sure we're efficient in the hospital. And we also want to make sure that our patients are getting back to work so our insurance product is successful and they can sell that we are actually helping them return employees back to work sooner. So that's a few thoughts that I have.
Thank you, Jeff. And I think that's a great point. It's so interesting to hear from Banner as a health system that's also an insurer. It's a unique perspective, but also I think you made some really great points there as far as reinvestment goes. And Dr. Martin, can we hear from you on this as well? Just sort of about what reinvestment looked like and the strategies, and then how you really maximized the value or the ROI on that investment as well?
Yeah, I guess from our perspective, it's many of the things that were just described, but it's also ensuring that we are as efficient and that we are sort of following best practices. So one of the things that we did initially was, Intuitive has a lot of robots. They have a lot of programs around the country. And the first question we asked is, okay, who out there is really kind of doing it really well right now? And they mentioned a couple of programs, and we actually sent our leaders to spend a couple of days at those programs, seeing what they do well. And we brought back a number of lessons. One of the lessons was we need a robotic coordinator. We created a robotic nursing position, a person whose job it is to eat, sleep, and think robotic surgery 24/7. The other thing we did was we created RNFAs. We didn't have any when we started the program. Now we have 8. We recognize from their program what the benefits of having experienced bedside assistance would be for every particular case in terms of efficiency and safety. We looked at the intuitive ecosystem. We brought in Genesis, and they took a snapshot of what the program looks like today. They've been back twice, and each time we've been able to improve a little bit. And so taking advantage of what Intuitive has to offer in terms of their macro program as well. And so there are a number of tools out there that are available. And this gets to the issue of really partnering with Intuitive. And, it wasn't always that way. It was at one point more of a transactional relationship where you sell us robots, we give you money, and that's the end of it. We've moved now to where you're helping sell and develop solutions with us to our issues. And that partnership is benefiting both Intuitive, and it's benefiting our clinicians, our patients, and our administration. So that's been the really big change. And we've developed that, we've grown it, and it's proved to be very beneficial to both Intuitive and to our institution.
Thank you so much, Dr. Martin. I think it's great to hear about how the partnership has developed and how that's changed over the years as well. Before we move on to the next question here, Dr. Battinelli,
Can I interrupt just for a second?
Oh, sure, Jeff.
Yeah, so I totally missed the ecosystem. I apologize for that. So let me just circle back around on that. So yeah, we worked very closely with our reps and really transformed a transactional relationship, as Jackie said, to one that's really sharing data. We're sharing big loads of data for 23 hospitals, 28, 29 robots, and actually doing comparison and showing our individual physicians the supplies they're using, their case duration compared to peers, and where those opportunities lie in improvements, both in outcomes, but also in cost. And with sharing that data, I also worked with our rep to build a pro forma that brings this information together so that when the CFOs get involved, it's not just a conversation about the cost of the robot. It's also a conversation about the advances, the improvements, the reduction of costs, the length of stay, and how all that can be weaved through a pro forma, and that you can share that with your leaders, those particularly making capital decisions on how this is benefiting the hospitals and the health system far beyond just a piece of capital sitting in the OR. So I just wanted to add that piece in.
No, that's a great piece, and I'm glad that you jumped back in, because I think that's really important, and kind of how it's not just talking about the cost of the initial investment, but also talking about how it could lower cost over time as well. Dr. Battinelli, can you chime in here too before we move on to the next question? Love to hear from you as well, as far as the reinvestment, and then also just how you maximize your investment as well.
Yeah, again, we also take advantage of the ecosystem, and obviously we learn a lot from peers, and that's critical to what we're doing. In terms of the reinvestment, it is simply making sure that we continue to plow forward, that we pace it appropriately, that we look at all the proper measures, whether it be quality, safety, et cetera, and the various other ways, as I'm sure you're aware, that we can do exactly what was just said, which was move away from what we hate, which are transactional relationships, to varieties of partnerships and innovative ways to do things via leasing and other, and really control the pace. And it was also already talked about. Yes, we have the same exact issues. People want to use SIs sparingly. Everybody want the XI, and the new stuff that you know is already coming. But we had to really take care of that organizationally on our governance committee. And it was very, very easy to convince people to continue to invest in the program, because the key issue for us was really incremental new volume that moved through, as well as continuing to capture volume that would have left the organization for similar technology. You know, we're in the greater metropolitan area. There's no shortage of competition, but that was our strategy, and it's not so dissimilar from the rest of our reinvestment strategy in whatever we do.
Thank you so much, and I think every single person that touched on this was, talking about a little bit about it. Just was almost an easy case to make, and it just makes sense when you lay it all out. So thank you each for weighing in on that question. I want to move on to our next topic here. And Dr. Martin, I'll start with you if that's okay. This question is just 24/7 or expanded hours access is a critical focus for many hospitals and health systems right now. Can you talk a little bit about how your organization is working toward making this a reality, and a little bit about, do your surgeons have unrestricted access to the technology? Just love to hear from you on this topic.
Yeah, I think that's a great question. And the first thing, of course, is to build a stable program during prime time, which is 7:30 to 5 p.m. Monday through Friday. We've been able to do that. But then, you hear from the surgeons all the time is, why can't I use a robot on Saturday, or Sunday or in the evening? Because this is a perfect candidate for a robotic approach. And the first thing is settling on a philosophy. And our philosophy is that, each patient should get the best approach, regardless of time of day or day of the week. And if you think about it, we offer open surgery and laparoscopic surgery 24/7. And yet we have this other technology that initially was restricted based upon programmatic barriers. Well, that didn't make much sense. And so we did the same things that we did to build a program. We got a small group together. We agreed upon the philosophy. We developed a strategy, developed a plan, put a group together, and executed. And so we do now offer robotic surgery. We started on weekends. We now offer it on weekends, Saturdays, and Sundays. We're expanding to weekday hours. And part of our philosophy is that robotics is no longer the special thing that only a certain portion of the OR staff know and do. Everybody's expected to be able to support robotic cases 24/7. Our only restriction is we don't do emergent robotic cases. We do urgent cases, we do elective cases, and we do add-on cases. And so we've been able to really create this idea that in terms of our service line, the option for open, laparoscopic, or robotic exists 24/7, 7 days a week, 365 days a year. That's been our approach.
And Jeff, can you weigh in on this too? I'd love to hear from Dr. Martin. It's no longer this special thing. It's everyone's expected to do it. So can you tell us a little bit about your experience as well?
Yes, I can. It varies by each of our facilities that have robotics. We have one program that has 5 robots doing 500 to 600 cases a month on each one of them, to single robot programs in more rural settings, which is the ones that I have. So obviously our trauma centers, similar to my colleagues on this webinar, you have to really address the trauma centers first and make sure that they have the levels. So I call it the big 5 in Banner, that really they need to have the 24/7 capabilities, while our other facilities try to build that in. What I saw is first making sure that Genesis goes through every facility, and then come back and do a review similar to what we heard before, to see what kind of improvements we made. Make sure that we have everything in order. Make sure we have the robot in the room correctly, so that we have the flow for our physicians and our staff working well. We also want to make sure that the equipment that's being brought in is consistent between the call teams that come in. We don't want to have extra equipment come in and then you have to reprocess it and do some various things with that. Bring in the necessary equipment, be trained enough for each team, and bigger facilities obviously have bigger teams, so they can actually have more people on call that are robotically trained. Ironwood and Goldfield, Casa Grande, my facilities, these are 120, 53 bed and 20 bed facilities that we have to make sure the team is trained that's on call, not only in open, but also laparoscopic, and also robotic. So we're taking a little different approach in that we're going to open that slowly. We're going to make sure our peak hours, like Jackie said, are filled. We're going to make sure that if we have a physician that wants to operate on a Saturday, let's open a block on a Saturday. But then we have to make sure our call teams are highly trained so that when a surgeon comes in for like an urgent case on a weekend or at night, they have a full confidence that our teams are trained and can handle the robot for them.
Thank you so much, Jeff. And Vicki, I want to turn the floor over to you now. I'm going to talk a little bit about expanding access as well. So you were one of the first to lease the Da Vinci system through intuitive financing. So can you walk us through like what that process looked like, and also just how it enabled you to bring robotics into a market that hadn't had access before?
Yeah, thank you. So when we first started our robotics program and we're contemplating the robotics program and looking at the pro forma, basically we felt that we had some risk. We had a significant number of providers that were very interested in the robot, but they were independent providers, which means they really could go to our facility or our competitor, basically where they had the best experience and their patients had the best experience. And although they wanted the technology, we needed a commitment from them in terms of how many cases they were going to bring to us if we added the technology and the platform. So we were excited to do that. However, adding the service line comes at a significant cost. And so we knew that we were going to have to probably spend the first 6 months to a year really developing the program. And for us, looking at that capital outlay at the very beginning felt to us that it was a little too risky. And so we were given the opportunity to lease our equipment. And basically what we did is we have a 4-year lease, but we also got a 6-month bridge. So for the first 6 months, we didn't have to make any payments actually on our equipment. So we could focus that first 6 months in getting a robotic coordinator. We were very, very blessed to get an experienced robotics coordinator that our surgeons trusted. And so that individual probably made it the easiest for us to really focus on our program and bring the experienced surgeons to our doors. But as well, we knew that we needed that basically that bridge so we could really focus on putting the money to training staff, marketing what we were doing differently, and how we would stand out from our competitor. Certainly we had to do a significant upgrade to our sterile processing department, and then certainly instrumentation and equipment. And so this first 6 months was really focused on that, and we didn't have to worry about making a large basically monthly payment on the system. So for us, financing for that 4 years with the 6-month bridge at a very competitive interest rate, and then no prepayment penalty, those were they were very enticing to our organization. And then of course, you think about that 4-year investment. Well, that 4 years came and went very, very quickly. And so we came to the end of that about actually 6 months ago, and then we're able to purchase it at fair market value, which was a very enticing payment plan for us. So for us, the financing really helped us get into a service line that we knew we needed, and also allowed us to kind of have the financial breathing room to really focus on developing the program and having a successful start out of the gate.
Thank you so much, Vicki. And yeah, it sounds like that first 6 months with the no large payments really helped you get things started on the right foot and really set you up for success. It's such a great story to hear. Moving on to our next question, Dr. Battinelli, I'd like to shift things back to you, just to hear a little bit about through your initiatives and just what you found, if you found that standardization throughout the OR and like what the value is in that.
Yeah, I mean, standardization for us as an organization, that's nothing new to the robotics program. It's similar in our ORs, all the equipment we use, our cath labs, we need to be interchangeable. We move our robots around, we move our programs around, so standards really do help. As far as standardization on the robot and quality and safety, as you know, we are one of the first, I think, to have a dual station simulator. We have hooked that up into our BioSkills laboratory. That we do have 24/7 access to. We have rules, and but it's mostly the trainees and others who are in there competing for time on the robot, literally 24 hours a day. That's been enormous for us to also help set standards for how people will move in and out of the ORs, and so that we can use the first assist program and the setups and the takedowns for the robots. Because again, that was probably, I've said it before, that was the critical link to really convince people who ran the ORs that we were not tying ORs up. As you know, ORs are expensive. If we could build another 20 of them, we'd probably do that overnight. But the next best way is to increase capacity in the ORs. So again, like Jackie and others have said, using nights, weekends, and other times. But standardization is critical so that we can have the type of interoperability that we want as an organization to be nimble.
Thank you so much. And we've worked through all the questions that I had for today. And so I thank you all so much for sharing your insight. Throughout our session today, we've had several questions come in from the audience. So I'd love to take a moment before we wrap things up today to address some of those questions as well. So the first question here that got come through is, with the end of the year rush for deductible surgeries we typically see, how will hospitals manage this influx during COVID? And is there anyone that would like to weigh in on that question today?
Sure, I can tell you what we're doing. This is Dr. Martin again. We do typically the last 2 months of the year, we get a big rush. And so what we are doing is expanding our weekend surgery option to Saturdays and Sundays. So that, and what we've told our clinicians is that we really don't know what COVID is going to look like over the next quarter. And so please take the opportunity now to take advantage of these options that we're offering for weekend surgery. Don't wait until the last 4 or 5 weeks of the year when we may have decrease in patient surgical beds because of the new COVID service line. So we've increased our offerings. What we found, and this may be true at your places, is that, the hospital empties out to some degree over the weekends. And so we have unutilized or underutilized capacity on Friday, Saturday, Sunday. And what we've said specifically is that we want inpatients with short lengths of stay, 24, 48, or 72 hours. Patients need to be out by Tuesday morning, and we bring them all on. We'll do whatever you want, Friday, Saturday, and Sunday. Just try to make sure they're out by Tuesday. And it's been a tremendous success for us. It's also been successful because if you think about the 8 weeks where we couldn't operate very much, our surgeons are trying to address some of their backlogs. They're looking at their individual bottom lines, and they're trying to recoup some of the financial losses that they've had personally. And they are taking advantage of this opportunity on the weekends to sort of clear up some of these patients and increase their numbers. So that's been our approach.
Thank you so much, Dr. Martin. And I want to go ahead and move on to this next question that we had come in as well. And anyone feel free to weigh in on this one as well. But this person just wanted to know, what's your starting point for an incremental system? So what parameters do you meet before you start considering next steps? Does anyone want to weigh in?
I'm
Jeff?
happy to weigh in on that.
Yeah, thank you.
Yeah, I've been doing this for many, many years on trying to help our facility grow and get incremental systems. And I think there's a slippery slope on really understanding, just looking at pure numbers. If you look at one facility that will do 275 cases on an XI, and another facility that will do 550, and say the one that has 275, well, they have all this capacity. Look what the difference is. When you dive in and really look at the utilization of the ORs from that 7 to 5, like Jackie was indicating, and let that peak time, and really see what's happening. Well, the facility that has 275 cases, their case hours are between 5 and 7 hours because it's an oncology program. So you're not going to be able to fit 4 or 5 cases into a day when you have those big, long cases. So I think you have to really look at your own data. I would say also, I have fought over the years of some parts of our organization, and probably many of your organizations as well, are afraid to share information or afraid to well, that's a vendor. Let's not get too close with them. Let's not, give them the information so we can better understand ourselves. I've tried to break through that and said, if I can give you the information and you can match it up on the robot information and blend this information together, the information that comes out is so robust and really understanding your operation. Together, we understand the operation better than either individual looking at their own data. I would just say, first off, understand your data implicitly. Make sure you understand your volumes, the types of volumes you have. Where do you have peak time and non-peak time? Just because we think that Friday afternoon is all wide open and that's capacity our surgeons should use. If they don't want to use Friday afternoon, it's not peak capacity. So I think what we need to do is really understand the needs of our surgeons and where they're needing to work and where our capacity exists.
Thank you so much, Jeff.
This is
And
David, if I could jump in as well, and I think that, as physicians on the panel, et cetera, we all know that all these doctors are not the same. So when we talk about measuring quality and safety, we're not talking about measuring it in aggregate. We're talking about the individual physicians. As you know, we videotape every one of our surgeries, and we have to feedback on these videotapes. And we've made incremental progress with certain surgeons. And just like, on the road, everybody thinks they're the best drivers on the road. Just all the surgeons think they're the best in the OR. And, Jackie's, doing the anesthesia there. He knows they're not all the same. And it's not a secret. And you got to measure it. And you got to demonstrate it to them. But when you give them the data, they will improve.
Mm-hmm. They will.
Great point.
thank you all. And Vicki, did you want to jump in on that question as well, or we can move on to the next one?
No, thank you. So I think for us, I think we're all kind of experiencing what that overload in the operating room's looking like with everybody trying to get their cases in. And certainly we know patients are trying to do the same thing. And for us, I think we've opened up certainly access to the robot for an elective case when a provider asks for it. And I think what we found predominantly is if we reach out to our surgeons that are on call for their weekend, they're a lot more likely to add that Friday afternoon case if they're going to be already staying locally for that Friday, Saturday, Sunday. So for us, we're really trying to figure out ways to make sure that the surgeons will reach out when they have a case that they want to add on. We want to also make sure that our provider steering committee is very involved in when we start looking at what's maximized time on our robot, our consults, and then what we need to do is if we really need to look at additional equipment or additional experienced staff in the operating room, those are the things that we want to be thinking about. But right now we're all experiencing the rush to the OR really to get the cases in by year end.
Thank you so much, Vicki. And we've had a few more questions come in from the audience, so I'll go ahead and move through those as well. So we've talked about this a little bit today, but not the specific question. So with surgeons that aren't willing to learn minimally invasive surgery techniques, how do you address these surgeons, and what do you do when they aren't on board with the overall vision? Would anyone like to weigh in on that question today?
Well, go ahead.
Only to say that this will not be for everyone. And I think it was already talked about this as a generational issue. I think there are many people, I'm one of them, I'm an internist, I'm not a surgeon. So I'll get out there and say, I don't know what day that's going to be and when, but at some point in time, there will be different categories of surgeons. There will be people who are able to do planned elective, minimally invasive surgeries under subspecialization. And then there will be critical care, trauma, ICU surgeons who will be capable of doing open procedures. And right now there's a little bit of battle sometimes between people who feel like you need to be able to do everything. It's nice, but it's not realistic. So there'll be certain cohorts that aren't going to move along. The only cohort I'm concerned about is the cohort who doesn't want to pay attention to the rules necessary to do the quality and safety. And we're quite strict with those groups.
Thank you so much. And Dr. Martin and Vicki, did either one of you want to chime in there as well?
I was going to say, I think the point you just made is correct. It's generational, and we have some surgeons who have developed certain procedures who are always going to do them open. But the younger surgeons who are coming up and coming through, and even who are learning within these under the tutelage of some of these senior surgeons, are moving to minimally invasive surgery because it's really the wave of the future. They recognize that, they want it. Our prospective residents who are coming and fellows looking at our program ask the question, what's my opportunity to learn minimally invasive surgery and do robotics cases? And if we don't offer that, we're not getting the best candidates. So it is generational. And, some old dogs you can't teach new tricks to, and that's okay. There's room for everybody.
Great piece of advice there. And Vicki, did you have something you wanted to add as well?
Yeah, I think kind of we've had the same issues, generational. I think, but the other piece of it is healthcare is more competitive today than it was, probably even 10 or 15 years ago. And I think for us, kind of as we really tried to encourage some of those surgeons that just didn't want to embrace the technology, they were really losing a fair amount of the market share, and we had to be cognizant of that. And so we've partnered with Intuitive to really make sure that our providers have the opportunity to really assess what the upside is. Maybe they're one of two surgeons from a cardiovascular perspective using the technology, and that really speaks volumes when you can get that information out to your public. So for us, even though some we had to maybe drag along a little bit, and even some are in their senior part of their career, but they also want to stay relevant, and they know that people will travel to get a quality surgeon. And so we want that to be in our market. And so certainly that's made a significant difference for us to try to bring some of those other surgeons along.
Thank you so much, Vicki. I think that's about all the time for audience questions that we have for today. But before we end things, I want to take a moment to have each of our panelists share one final thought, piece of advice for everyone who is tuning in today. So, Jeff, let's start with you, and then we'll just work round robin through all the panelists here.
Yes, happy to. Thank you. I'm just going to reiterate something that I stated earlier, and I think it's an important element that I've certainly learned over time, and I've seen other programs develop by just opening themselves up with Intuitive. I fought this for a very long time. It took me a year, literally a year, to get a data sharing agreement put in place so that we could match up our data and really get the most robust outcome that we can. And what's really been amazing is that initially people didn't want us to do this because we have our own data. It's the best data. We don't need any other data. Now, when we've married this data up, and you actually can go in and look at schedules, you can go in and look at the overall efficiency of the robot. You can marry up some of the supplies, the cost, put a pro forma together, have a presentation all put together that actually helps and doesn't impede the storyline that you're trying to share, whether it's for 23 hospitals, a large system, one robot program by itself. If you share the information, you're going to get so much robust sharing of knowledge that it's incredible. And I knew it would happen, or I thought it would happen, I guess would be a better thing to say. But now ultimately seeing the results, I would encourage anyone to really work with Intuitive and understand their program.
Thank you so much, Jeff. And Dr. Martin?
Yeah, I agree with everything that Jeff said. And I would say that it's really a matter of partnership, right? With not only with Intuitive, but with your administrative folks, so that, in the early days, it was going to administration, asking for something, and then trying to tell them the story, right? And the difference now is that they're part of the journey now. They're part of our robotic steering committees. They understand what we're trying to do, where we're going, what we need to get there. And so when the ask comes up, it's not a surprise. It's not anything new. They've been along for the journey and understand what we need to continue to grow the program. So I think it's partnering with all of our customers, and our customers are our patients, our clinicians, Intuitive, everybody, and just making sure we have good, open communication. We're not always going to agree on the same solutions, but we're always working together to find good solutions that in the end will help grow the program and provide real value and benefit to everyone.
Great final thought there, Dr. Martin. And Dr. Battinelli, we'll move to you now.
Yeah, again, I agree with what everybody said so far. And probably in retrospect, one of the things we did that was very, very useful is we had a great program manager who really is our lead. Everybody works through him. And he's also put in place a number of other people who either lead the first assist, who are the key people in finance to make that key translation to, what makes finance sense. Everybody thinks it makes sense until you talk to finance. You don't have any friends if you don't have any friends in finance. So These are some key people to help us move the program forward, and then sharing in the ecosystem. And this is not a brand new technology. It's been around for a while. People have learned a lot, and it makes sense to talk to your friends.
Thank you so much. And Vicki, one final thought before we wrap things up today from you as well.
Yeah, thank you. So I think as has been mentioned before, is the partnerships, whether it's with your administrative team, but for us, it's as well having a great physician champion that really wants to always just make sure that we're staying relevant in what we're doing and we're moving the dial and having a very energetic steering committee. I'll be honest, there are times that kind of the energy waxes and wanes based on surgeon schedules, but it is so important for us to stay engaged and make sure that we really are, looking at that data and really trying to move the dial. And also just looking at whatever technology is going to help enhance our program. And for us, we got the simulator. We actually make our simulator available to any surgeon in the state of Montana, because we know that having somebody that can get consult time, get on that simulator to prove quality is essential. And then also we did invest in the motion table that we think helps our patient outcomes. But really, at the end of the day, it's wonderful technology, and I would never minimize that. But it's really about building a program that sets you apart from your competitor. And we believe that that's essential for us. We want to make sure that the data that we have via the ecosystem, that we know it internally, we share it, but we also make sure that the surgeon has a right to vote with their feet which facility they want to use. And we want them to have a great experience here using our technology. And then certainly the patients, the same thing. We have to focus on really making sure that we've got a very great program that brings the patients and the doctors through the door.
Thank you so much, Vicki. So much great advice today. I want to once again thank all of our panelists for taking time today to share their experience and insight with us. Sorry, our session today did go a little bit longer than anticipated, but there will be a short break and then we'll come back to the general session. So thanks once again to all of our panelists and everyone tuning in today.